Very good evening to one and all. Today we are having a guest speaker, Dr. Shankar Subramanian. He is working as a consultant ENT surgeon in Apollo Hospital. He is going to talk about mucormycosis. During this COVID period, the rising case of mucormycosis, also known as black fungus, we must have some idea what to do, how to manage. He will give a detailed lecture about mucormycosis.
So, good evening, one and all. It's a pleasure to meet you all for this presentation. This COVID-19 second wave is already creating a big catastrophe all over India. And just when we were hoping that we will cross somehow without much loss, another entity has come to the talks for the last 10 to 20 days, which is already creating enough panic among the common people. So 3-4 days back, Dr. Vinayak called me and asked me to give a lecture on the mucormycosis. And as you all know that Search Test is committed to always providing the latest updates on each and every topic in medical field. And this presentation is no such exception. So, but what was surprising or shocking is that in a span of 3-4 days, I myself saw 3 cases of mucormycosis. Which I thought it's quite shocking, and the presentation was so disturbing that the upcoming challenges will create a little bit of panic initially among the medical fraternity, and hope that we come across this this one as. So this presentation and this session is not only for Search Test members but also for the other specialists from various fields. So I've tried maximum to just cover almost every information, right from the basics to the latest management protocols, so that different sectors of the audience will get benefit from the presentation. So we'll start with the presentation. So just the last 3 days, I have been thinking of what topic, what title can be given for my presentation. I just came up with this Mucor, the known enemy. And over a period of time, we'll be knowing why I give this name. So I'm Dr. M. Shankar Subramanian. I'm a consultant ENT surgeon in Apollo KH Hospital in Ranipet. I finished my MBBS in Kilpak Medical College, Chennai, and I did my master's in ENT from Stanley Medical College. So why this presentation? I'm sure this picture has been going viral for the last 5-6 days, when a 35-year-old youngster was declared dead because of mucormycosis. And as you all know that the media have started reporting various news in various platforms. So of which the few were the rising number of cases, almost like close to 500 cases per state as reported by the India Today. The BBC India quoted this stated headlines as the black fungus maiming COVID patients in India. Also, 2 days back in the Twitter handle, the Rajasthan government declares black fungus as an epidemic was created a bit of a buzz for some time. So already there is, as I said, that there is enough panic among the people of India. And with this new thing, I am sure that it's going to create more confusion and many questions for the public. I hope that we as a medical fraternity, as a community, we try to help fellow colleagues as well as the common public. And this meme has been circulating in our WhatsApp group for the last 4-5 days. But I beg to differ from this meme, because I'm sure by the end of this presentation, we all will realize that it's not only an ENT surgeon who will be playing a major part in this black fungus, but also specialists from almost every medical field will be playing an important role to tackle this challenge. So the known enemy, the COVID-19 last year gave us a lot of challenges. Even now it's giving a lot of challenges, because it's been like almost 1.5 years and still the etiopathogenesis, the course of the disease, the management and the prognosis, it's always been an atypical. And day by day, the symptomatology has been varying, and the atypical presentations are becoming more common. But unlike the COVID-19, this mucormycosis, which now is informally called as an black fungus, even though it's a misnomer, is not a new entity to the medical fraternity. The literature dates back to many years ago, and the etiopathogenesis, clinical features, management have been described in literature. Still, it's a frightening enemy with high mortality, with mortality rates almost accounting up to what 50% worldwide. So we'll start with the fundamentals from the microbiology. So fungi are nothing but eukaryotes, depending on external source of nutrition, and may consist of hyphal elements or unicellular organisms. Fungal infections were a rarity in the past, with the predominant problem being allergy, mycotoxicosis from ingested toxins, and mushroom poisoning. The taxonomy, the classification of a fungus can be done in 4 ways, like Ascomycota, Basidiomycota, and Zygomycota, and Deuteromycota. Of this, the Aspergillus species belonging to the Ascomycota should be noted, and the Zygomycota, the Mucorales and the Rhizopus. The term, initial term zygomycosis is now being replaced by mucormycosis, and the species which belong to the Mucorales or Rhizopus species, Apsidia species, Mucor and Mucor species. So this mucormycosis or the black fungus is nothing but an form of fungal sinusitis. Fungal sinusitis can be classified as invasive and non-invasive based on tissue invasion. And invasive fungal sinusitis again can be classified as acute fulminant or acute invasive fungal sinusitis, chronic invasive, and chronic granulomatous. From this moment onwards, this discussion on this PPT or this presentation will be revolving around only one entity, that is nothing but acute fulminant or the acute invasive fungal sinusitis. 2 major organisms cause this disease. They are Aspergillus species and the Mucor species. So the etiopathogenesis, a number of factors contribute to the development of this disease in an individual. They are nothing but all those factors will cause an immunocompromised state in an individual. So examples like diabetes mellitus, leukemia, lymphomas, aplastic anemias, hemochromatosis, acquired immunodeficiency syndrome, and hypergenic immunosuppressions like systemic steroid therapy, which is the major culprit in this COVID-associated mucormycosis, and chemotherapy with neutropenia, prolonged antibiotic therapy, or post-organ or stem cell transplantation. So basically, this fungi is claimed to be present all around us. These fungal spores, when inhaled, they get trapped in the paranasal sinuses, and over a period of time, in an immunocompromised individual, they undergo proliferation, and gradually they invade the blood vessels, and which in turn cause necrosis, bony erosion, and ultimately dissemination. A small correction, like a few seconds ago, it's not gradually. This condition will take place in like hours to minutes. So that's that from the onset till the presentation, you will not believe that how quick the progress was. So as I said, that multiple factors ultimately contribute to the invasive fungal sinusitis. We cannot pinpoint one particular factor, but it's just an interplay of various ecological factors. Of these factors, 2 factors need to be mentioned. One is the role of iron and the role of diabetes mellitus. Iron, there are 2 mechanisms proposed. One is the direct effect of iron, which helps in the growth of every microorganism. In animal models of mucormycosis, iron and desferoxam promote growth and increase the virulence of Rhizopus organisms. Secondly, excess free iron impairs the natural response to infection through complex mechanisms, including inhibition of interferon gamma, TNF alpha, and impairment of macrophages, neutrophils, and T cell functions. Diabetes, As you all know that uncontrolled diabetes will give rise to diabetic ketoacidosis. Initially, in a normal serum, has the properties which inhibits the growth of mucorales. Serum acidosis permits growth of rhizobus species. Studies have been conducted in the past which states that acidosis inhibits transference capacity to bind iron, thus allowing rhizobus species to use it for growth in vitro. So clinical features, we'll be seeing a number of clinical features over a period of time, even in the presentation itself. But as in just a small introduction, the clinical features can vary from as minimal as a normal nasal block or nasal discharge, and it can extend up to till the necrotic ulcer at the time of presentation. These clinical features can be divided into three stages: rhinomaxillary, rhinoorbital, and the rhinoorbitocerebral. So in the rhinomaxillary stage, so the symptoms will be like a common nasal obstruction or nasal discharge, sometimes bleeding from the nose, and blackish discoloration of the bridge or the dorsum of the nose, and black crusting, and also mild facial pain. As the disease progresses to the orbital stage, all the eye symptoms will slowly can occur, and eye symptoms will range from eye discharge or eye congestion to diminished vision, vision loss, and diplopia, and other ophthalmoplegia. As the advanced mucormycosis, the cerebral component will be affected when the patient will have an altered sensorium, multiple cranial palsies, and loss of consciousness as well. So, except for those who present at a very early stage, most of the patients with significant mucormycosis will present at a OPD with a similar kind of picture, where you can see at least one part of the face where the eye is completely chemosed and congested, and will not be able to just open the eyelids even actively or passively. And there will be crusting around the eyelids, and there will be facial edema significantly on one part of the side. Secondly, the endoscopic picture of the nasal cavity will give a picture of some serosanguinous dirty colored discharge. In case of advanced cases, you can have a necrotic tissue or blackish scar in the nasal cavity. One important component of the clinical examination, which one of the important take-home points of this presentation will be the examination of the palate. Often, the examination of the palate will be missed during the routine examination, but in case of mucormycosis or invasive fungal sinusitis, the examination of the palate is absolutely essential. Whereas starting a mild discoloration to an frank ulcer can be missed if not examined. Also, the examination of the tongue is important. Sometimes we can find a necrotic ulcer or a black eschar. So, as far as the investigation is concerned, two important investigations: one is the radiological, and as well as the pathological and microbiological investigations play a definitive role in the diagnosis. So, for all those non-ENT friends of this presentation, this is a CT PNS of a normal individual. So, these two are the orbits. This is the maxillary sinus, and this forms the ethmoidal sinus. This maxillary sinus, now it appears black in color. It means like it contains only air, which is a normal thing. And also the nasal cavity, you can have just one is almost, there is no significant abnormality. You can see almost black these spaces, which indicates that it's a normal nasal cavity comprising of just air. But CTPNS is one of the fundamental investigation in mucormycosis, because a lot of signs and features can be identified in the CTPNS. As you all know, as you see in this CT scan, almost the left maxillary sinus as well as the left ethmoidal sinus are being affected as a complete opacification. Literature says that a small irregularity in the lamina papyracea with minimal intra-orbital fat stranding can be considered as an early sign of invasive fungal sinusitis. And again, there's another picture of the axial CTPNS where the opacification can be seen. And again, the periantral fat that is really, near the maxillary sinus infiltration or the stranding can be considered as an early sign for invasive fungal sinusitis. Though CTPNS, other than this opacification, we can see bony erosions, etc. At present, for mucormycosis, especially for early diagnosis, an MRI brain with contrast involving the orbits as well as the paranasal sinuses is the investigation to confirm or at least to highly suspect that it is a case of invasive fungal sinusitis. Again, this MRI picture shows that left periantral fat stranding here. And this is another case of fungal sinusitis where both the sites are involved with infiltration in the left orbit. In case of cerebral mucormycosis, the enhancement of the leptomeninges is considered as a sign of advanced mucormycosis. So, as we saw now, a thorough clinical examination, of course, with a detailed history and a radiological examination, we can highly suspect, or in fact, we can almost confirm the possibility of an mucormycosis. But the definitive investigations will always be the histopathology. And considering of three components, one is the histopathological examination and microbiological examination, namely KOH mount as well as fungal culture. Histopathology, the main role of histopathology is the demonstration of fungal elements, identifying tissue invasiveness, identifying the type of inflammatory reaction. Two important stains are implied in the fungal identification. One is CPAS and a Mucormycosis stain. These two stains are not specific for fungus because they not only stain fungus, but also the collagen bands and vessel walls will also appear like fungal elements. But fungus are further identified by structural characteristics. So invasiveness of a disease is determined by the presence of fungal elements in the submucosa, invasion into the vessel walls and the lumen with consequent vascular thrombosis and infarction of the tissues. While in a chronic disease, the inflammatory, chronic inflammatory cell component, and in case of a granulomatous disease, a granulomatous reaction can be identified. So this is an example of a PS stained section where you can see an aseptate fungal hyphae. And as I said, one first take-home point will be the examination of the hard palate. The second point, as far as the histological is concerned, the aseptate hyphae and septate hyphae. So, of the three investigations I just mentioned, which are histopathological examination, KOH mount or calcophore white stain, or the fungal culture. The KOH mount will give us a early picture of the involvement of a fungus. So aseptate hyphae means that it's mucormycosis, and septate hyphae means it's aspergillosis. So it's another PA stain section where infected adipose tissue is shown. So as I said that KOH wet mount, potassium hydroxide, the basic principle is digests proteinaceous material and debris and allows visualization of fungal hyphae under a light microscope. So this is a picture of the septate hyphae of aspergillus. This is a aseptal fungal elements, means mucor, most probably mucor, and the calcophore preparation. And this is again septate fungi. So the management of mucormycosis, that's it's like all the literature as well as the journals, they describe that component as a very exhaustive as well as a myriad of challenges. So what are these challenges and what are the approaches? So we cannot specifically say this is the treatment for mucormycosis or the invasive fungal sinusitis. It's a multidisciplinary approach as well as a multimodality approach. So again, one of the important slides of this evening, algorithm for diagnosis. So as far as the post-COVID condition is concerned, so COVID affected patient or post-COVID patient who were treated with steroids or with history of diabetes, with the history or suggestive of any one of the symptoms or signs, the first step immediately should be a diagnostic nasal endoscopy to look for any changes in the mucosa and simultaneously imaging, radiological examination. So with these two investigations, we can come to a conclusion whether there is a chance of fungal sinusitis or not. A strong suspicion of fungal sinusitis will be supplemented by a tissue biopsy or the KOH mode to confirm invasive fungal sinusitis. So minor criteria and major criteria, as I said, that minor criteria involves the nasal discharge or stuffiness, ulceration, epistaxis, periorbital swelling, maxillary tenderness, black necrotic lesions of the palate. Major criteria involves radiological evidence of sinus invasion, that is erosion of sinus walls, extensive skull base destruction, and neighboring structures. So treatment. From a general point of view, there are only two modality of treatment. One is the surgical debridement and antifungal therapy. But for these two alone will not suffice, because the major component will be like treat the underlying condition which has caused the immunocompromised state. So aggressive surgical debridement and antifungal therapy remain the mainstay of the treatment, along with the treatment of the original cause, underlying causes. So as I said that the surgery, it depends upon the sites and extent of involvement. So a team comprising of an ENT surgeon, ophthalmic surgeon, or oromaxillofacial surgeon and plastic surgeon is important to formulate a plan of action and subsequently the surgical debridement of the condition. So antifungal, two important groups are useful in the treatment of invasive fungal sinusitis. One is the polyenes and the other one the azoles. In the polyenes, of course, the topic of discussion for the next 10 to 15 days will be this drug, the amphotericin B drug. This mechanism is for the exam quiz. So this amphotericin B binds to the ergosterol in fungal cell membrane. It forms a micropore so that the inner part of the cell becomes permeable, hydrophilic component, so that the amino acids and water-soluble substances move out, which ultimately result in cell death. This amphotericin has got various formulations, but the most important, the need of the hour, and the savior of the situation will be liposomal amphotericin B. It is a formulation of the amphotericin which has got improved response rates and survival. It has got less nephrotoxicity and improved CNS penetration, and it also lowers the inflammatory response. Whereas the amphotericin B deoxycholate is pro-inflammatory, and the liposomal amphotericin B, yes, it's expensive, and the current guidelines say that at least for 3 weeks, this amphotericin B should be given. So basic outline of the treatment, clinical suspicion of an invasive fungal sinusitis with a thorough history and examination and radiological investigation and biopsy. Once the diagnosis of invasive fungal sinusitis is arrived, without any further delay, the surgical debridement should be done, followed by systemic antifungal therapy. So this antifungal therapy consists of 2 phases, induction phase and consolidation phase. In the induction phase, the amphotericin B should be started. Once the treatment is working and there is a significant clinical improvement, then the treatment can be stepped down to oral posaconazole or voriconazole, followed by constant monitoring for almost 3 to 6 months. So as I said that two important organisms are involved in invasive fungal sinusitis. One is the Aspergillus and another the Mucormycosis. So as I say, the treatment will be like this. So any condition or any patient with clinical picture suggestive of an invasive fungal sinusitis with immediate surgical debridement. As an empirical therapy, we can start with amphotericin B. Once the fungal results come, and if mucormycosis is ruled out, then amphotericin can be stopped and voriconazole can be started. But any state, mucormycosis should be the first suspect, and the factors which are favoring mucormycosis over aspergillosis right from the historical dates are epidemiological clues like institution with the high background rates of mucormycosis, iron overload states, hyperglycemia with or without diabetes mellitus, and prior voriconazole or echinocandin use. Clinical, radiological, and laboratory clues like sinusitis features in the CT scans and MRI, and oral necrotic lesions in the hard palate or the nasal turbinates, serosanguinous blood-stained or dark nasal discharge, and repeatedly negative serum Galtaman. This Galtaman is a test mainly associated for aspergillosis. If it's negative, then the clinical picture is suggestive of invasive fungal sinusitis, mucormycosis can be finalized. So just an outline of the various drugs which can be used for invasive fungal sinusitis. At present, our drug of choice, drug of interest will be liposomal amphotericin B. So the dose is 5 to 10 mg per kg per day. And as I said that it has got less nephrotoxicity and good CNS penetration. And minimal period of administration will be starting from at least 3 weeks. Or in case if there are early mucormycosis and after a very good surgical debridement, and that's a significant clinical improvement, amphotericin can be stopped before also changing to the oral fluconazole. So these are the in case it's a case of invasive aspergillosis, the drug of choice will be voriconazole, primary therapy. And in case if not available, or liposomal amphotericin B can also be used as well. So in addition to this surgical debridement and antifungal therapy, and of course, as I said, that treating of the general condition of the patient, reversal of the inciting factors. And these are the adjunctive therapies which have been described in the literature, and I'm sure that none of these methods will be experimented in the at least the next 2 to 3 months, because none of the methods have been, of course, there are no sufficient evidences in the literature to initiate this therapy. So these are hyperbaric oxygen therapy has been known to provide benefits in case of mucormycosis, but the pressures and the cycles and the duration have not been mentioned in the literature. So iron chelating agents and the immune augmentation strategies like granulocyte macrophage colony stimulating factor, and immunomodulators like mTOR inhibitors and calcineurin inhibitors can be tried in case of invasive fungal sinusitis, but the response and the benefits have not been documented yet. Statins and colistins have also been implied in the treatment of invasive fungal sinusitis, but with a lack of evidences. So coming to the COVID-associated mucormycosis, the present hot topic all over country. So already the first case was reported in the month of March, and it was published in the month of May. So in this study, it has mentioned that the incidence of mucormycosis worldwide is ranging from 0.005 to 1.7 per million, whereas in India it's almost 80 times higher compared to the developed countries. As I said in the beginning, that mucormycosis in general per se itself has a high mortality rate of 46%. In India, that rate can be as high as like 50 to 80%. So in COVID-associated mucormycosis, the predisposing factors most commonly the excessive usage of steroids. So many factors can be implied for this, because in the first wave last year, steroid played an important role. Of course, even now in the treatment of COVID, steroids play a definitive role. But in the second wave, with increased number of cases, there's a lot of over-the-counter buying of steroids by the pharmacist or even by the general public itself. So improper or like early or excessive use of steroid is an important cause for this black fungus. And diabetes, as usual, uncontrolled diabetes, which again exaggerated with the help of steroids, can be a predisposing factor for mucormycosis. And patients who have been underwent post chemoradiation or with other comorbidities, they all should be suspected of mucormycosis at the earliest possible symptom. So this is one of the PDF. I am sure by now most of you would have got in your mobiles. So Fungal Infection Study Forum has given the guidelines to approach this COVID-19 associated mucormycosis. Most of the points we have just already seen, but important point I have to mention for this slide is nothing but will be the amphotericin, how to administrate amphotericin. See, of the, I'll be just saying about what are the challenges as a medical fraternity we are going to face in this mucormycosis. Of this, one of the challenges will be this administration of amphotericin B. I am not sure about, I'm not sure how much all the ward staff nurses who are administering the medicines to the patients know how to administer liposomal amphotericin B. So I just want to recall an incident during my first year MS. Myself and my co-PG were allotted a duty to administer liposomal amphotericin. It was not liposomal amphotericin. It was just plain amphotericin for a case of rhinocerebral mucormycosis. And I'm sure that I just remember the exact picture that as soon as it was administered, within a span of 7-8 minutes, that patient started producing so much adverse reactions, starting from chills, rigor to breathlessness. But liposomal amphotericin B is known to produce less side effects, but it should be administered in the correct way. So the correct dose will be 5 mg per kg per day, but it can be like up to 10 mg per kg per day, depending upon the severity of the mucormycosis. So before giving amphotericin B, patient must be infused with normal saline. After that, accordingly, the dosage should be calculated according to the weight, and it should be diluted in 200 ml of 5% dextrose, and it must be infused over a period of 2 to 3 hours. So this is an important factor which all the healthcare workers who are going to administer this drug for the patient should be educated on how to administer amphotericin B. So again, as far as this release is concerned, another important point will be the use of tablet posaconazole, 300 mg twice a day on first day, followed by 300 mg once a day. So this will be the therapy in case of consolidation phase, or in case where the amphotericin B is not tolerated by the patients. So this is Indian Academy of Otorhinolaryngology guidelines for mucormycosis. Again, I will be highlighting only the important points other than the discussed ones. So here, just like another, just like I said, how to administer liposomal amphotericin B. This is an important slide, and it must be borne in mind in all the ENT surgeons as well as all the healthcare professionals. So how to send a sample in the OT. So as all surgeons usually deliver the specimen and give it to the OT technician and ask him to send it to biopsy. So they usually, most of them, 99% of the specimens will be sent in formalin only. But in case of mucormycosis, or in case of an identification of a fungus, for KOH mount, it should be sent in saline. Again, for culture, it should be sent in saline. Only for histopathological examination, it should be sent in formalin. Again, this is an important feature because it's as important as like getting a biopsy. It's like it should be made sure that it's correctly sent to the lab. So how to treat mucormycosis? As I said that it is a multidisciplinary approach. Where constant consultation with a physician, endocrinologist, ophthalmologist, pulmonologist must be done, because a mere surgical debridement alone will not be enough to treat mucormycosis. Amphotericin B must be administered. As I said that all the adverse reactions should be kept in mind and they should be managed accordingly. At the same time, the underlying immunocompromising conditions should be managed. So it's a teamwork and a constant discussion about the patient with the fellow specialist is a must. So the first line of treatment, as I said, surgical and medical management involving liposomal amphotericin B. The second line will be treatment failure of the first line or renal failure, toxicity to amphotericin B. In that case, posaconazole. So after 3 to 6 weeks of amphotericin B, consolidation therapy of posaconazole for 3 to 6 months. So again, as I said, the patient should be constantly monitored. Just in case if the patient condition is deteriorating, there should not the repeated surgical debridement must be considered with associated radiological investigations. So what are the challenges we will face in COVID-associated mucormycosis? See, there are two. We can classify into two groups. One, those patients who completely recovered from COVID, they present to the OPD with again symptoms of mucormycosis. One category. The other category, active COVID patients with mucormycosis. So in such cases, the clinical examination in a COVID positive patients is so challenging, because right from the as ENT surgeons, right from the endoscopes to just getting a tissue sample, it requires a lot of efforts, because we need this personal protective equipments and all the sterile measures, so that none of us or all the other health workers should get exposed. Second thing, the time of intervention. As I said that I am constantly in discussion with my pulmonologist here about when to start or when to intervene in case of an active COVID and also an active mucormycosis. So according to him, and as per also with the current recent studies, they say that in case of a mild COVID, after 7 days, we can go for intervention. In case of a moderate COVID, 10 days. In case of severe COVID, only after 14 16 days, active intervention for surgical debridement should be done. Then another important challenging factor is GA, general anesthesia versus local anesthesia. We ENT surgeons, for us, the general anesthesia is a paradise, because when operating in the nose, when the airway is secured, we'll be concentrating on our part. But in a COVID positive patient with active COVID, it's impossible to give a GA. And in case of an LA, there are a lot of factors, because already the patient saturation will be fluctuating. And when we are going to operate in the nose, there is always a risk of aspiration, so many things. And in between all these things, we'll be operating with a PPE kit also. So these are the challenges. And time of recovery, yes, it all depends upon the general condition of the patient, the drug therapy, etc. And beds availability and dedicated COVID-associated mucormycosis ward. So because this, one of my friend who is an anesthetist, is in Madhya Pradesh, and he just now, 2 days before, he told that in his hospital, there's a separate ward dedicated purely for mucormycosis. because the cases have been increasing on a rise, and to treat or to manage a case of mucormycosis, it's not sufficient to have just a OPD setup and OT setup. It needs a setup where all the specialists are available all the time for the management. And of course, the current hot topic, and which will be in the news for the next 10-15 days, is the drug availability. Liposomal amphotericin B is the drug of choice, and it is expensive and it's not easily available. Already, friends from Hyderabad, Salem, and other parts of Tamil Nadu have already been asking regarding the availability. And even for patient which was operated 2 days ago, we managed to get only amphotericin only for the first 3 days, and the next two remaining amphotericin B, we are still in question mark. And as I said, multidisciplinary approach. See, in COVID in the last 1.5 years, you all know that a hospital with the oxygen facility and ICU facility, with the help of an anesthetist or intensivist and a pulmonologist or a physician, they have been treating COVID. But as I said that in case of mucormycosis, it's not only an ENT surgeon, it may requires an ophthalmologist, it requires an pulmonologist, an endocrinologist, almost every pathology, a very good pathologist and the microbiologist. So it's a multidisciplinary approach, and with already the COVID pandemic is creating a lot of challenges and the demand for healthcare workers or doctors. This mucormycosis, I'm not sure that how early we are going to cope up. So this is a video of diagnosing nasal endoscopy of a normal patient. So this is inferior turbinate, this is middle turbinate, and this is the septum. This is the right side of the nasal cavity. As you all know, as you all can see that it is a normal mucosa. There is no significant any abnormality. The reason why I'm showing is, if at all there's a situation arise that where specialists other than ENT must diagnose mucormycosis. So I thought this will be useful. So this is how a normal looking nasal mucosa will be there. So this patient, as I said, that she's a 58-year-old female with uncontrolled diabetes. She was affected. She was having her first symptom of COVID on May 1st. She presented to the NDOPD like 2 days back with history of eye swelling, loss of vision in the right eye, and right facial swelling for 5 days. She was discharged. She was discharged after undergoing treatment for COVID, and after 3 days of discharge, she developed all these symptoms. On examination, on clinical examination itself, patient was in case of she was responding to oral comments, but examination could not be done because there is always a possibility that COVID infected with the COVID. So she was admitted. Patient RT-PCR was done, and IgM and IgG antibodies were done. Both were positive, but we had no other option other than intervening. So as I said, that which much protection and more possible safety kits, we intervened. Since it's an active COVID, general anesthesia cannot be given. So it was done under local anesthesia. So you can see the left eye almost normal. On examination, it was normal. But right eye, already patient came with the proptosis. There is always protuberance of fat, and pupils are not reactive on the right side. So first we proceeded with the diagnostic nasal endoscopy. As you see that so compared to the previous video, already there are some dirty colored discharge here. Also, there were characteristic black crust. So on suction, you can see the serosanguinous purulent kind of discharge in the right nasal cavity. So this is almost one of the characteristic like discoloration of the nasal mucosa. Yeah. So characteristic blackish discoloration of the nasal mucosa. You can see here also. And this is the right side of the septum. You can see is not a normal looking. So as a first part, we took as much a biopsy possible from multiple sites. As I said, that patient was taken under local anesthesia. So now we try to open the right maxillary sinus. You can see the discharge coming out of the right maxillary sinus. So this is the right maxillary sinus. So once it was opened, suction was done and wash was given. And this is an instrument called the microdebrider. With the help of this, debridement of the dead tissue and debris was done. And coming back to that, as you said that the patient was taken under local anesthesia. Even though when a patient, when the surgery is taken under local anesthesia, the field will be relatively bloodless. But this is not a usual one, because in fact there was no bleeding at all, and owing to the generalized septic shock condition, I didn't infiltrate much. So, but since even then there was no bleeding at all, and through this process, patient did not wince with pain, did not wince with any pain, did not complain any pain at all. So it's meaning that entire the vascular supply and the nerve supply of the right side is being compromised. So just try to open the sinuses as much as possible, as quickly as possible, because throughout the process, at one point, the saturation was fluctuating. The heart rate was ranging from bradycardia to tachycardia. So this is the nasal septum. Initially, we thought the debridement was enough, but again, there was a blackish discoloration in the septum as well. So we debrided till there was bleeding, and as well as still patient complaint of pain. So I will not say that I was completely satisfied with this, but given the condition and under local anesthesia and given the situation we were in, I thought for at least for the initial part of the treatment, this is more than enough. So we are awaiting the KOH mount results by tomorrow, and HP results by Monday morning. So patient was started on amphotericin B. As of now, There's no significant improvement, but the patient attenders, according to patient attenders, they feel that their subjective improvement is there. But as a whole, the condition is kind of worse only because at the time of admission, the total counts were the range of 26,000. And even after 4 or 5 doses of higher antibiotics, it's still the same. So another patient for 50-year-old male, diabetic, post-COVID, 17 days. He developed right eye discharge and right orbital pain. Again, CTPNS showed a right-sided sinusitis, but there was no any erosion. So diagnostic nasal endoscopy was done. Only this area was suspicious. Other than that, all the remaining mucosa were quite okay. So we just took a biopsy alone, and we are just waiting for the result. And one of the other challenges I forgot to mention is that see, at present in our setup there are certain hospitals which exclusively treat COVID patients. But whereas in my hospital or in certain other hospitals which treat both normal as well as COVID patients, the investigations, especially the radiological investigations, they allot certain timings for the COVID patients. So, for example, if I want to take an MRI for this patient, I have to wait till evening, and the results will be available only by tomorrow morning. So, all these challenges will be an important part in treating the mucormycosis. So, the take-home points of this presentation will be that with the history suggestive of anything related to mucormycosis, we have to watch out for every possible sign and symptom. And early investigation is a must. And in this case, there should not be any hesitancy to do any investigations. If you feel that it's better to do an MRI, straight away proceed and modify the present drugs for the COVID treatment, taper off the steroids and start the antifungals, and not hesitate to call for help. Anyone you want to have a conversation, just call for help, because like regarding this case, I think it was 12 midnight. I was just texting my mentor, my professor, and he was gracious enough to reply and solve my queries. So do not hesitate to call for help. And always, as I said, that have a discussion with the radiologist, pathologist, microbiologist, and pulmonologist, because only if you say them what you're expecting, and they can help you with that. Adequate counseling for the patient attenders is a very, very important point. And I hope that every one of us will handle this thing very carefully, because as you all know that by now there's a general understanding in the public. If 100 people are affected by COVID, 20 are getting sick, and among the 20, 10 are extremely ill, and maybe like 4 to 5 they meet with death. But as we just saw that in mucormycosis, the chance is 50-50, and with the challenges we just saw and in our country, the rate can extend up to 60 to 70%. So realistic expectations about the treatment, about the outcome of the treatment is absolutely necessary, because the treatment is not a hit or miss. It is a long course of treatment, and with the associated conditions, one may not predict the prognosis. So adequate counseling of the patient for the patients and attenders is absolutely necessary. An informed consent before doing anything, because certain things it will be for an ENT surgeon, the debridement can be a very easy. I won't say easy. It will be a tempting factor, because we know we can intervene and we can do something good for the patient. But at the same time, that we have to make sure that post-surgical debridement, whether we have a very good setup for the all-round care patients. At the end of the day, we have to take care of ourselves. I just told that And there have been like 10 to 15 of us who have been doing surgery, just general surgery for COVID-19, active COVID-19 patients. Even though we took all the necessary precautions, at the end of the day, that there is always that fear that which creeps hard that at what point we may start showing some symptoms. So just we have to take care of ourselves also. So as I said that from the beginning of the presentation, it's a known enemy. Napoleon said that it's better to have a known enemy than a foe ally. Yes, of course, once the enemy is known, that we know what to do and how to tackle. And I hope that this mucormycosis, even though it poses a serious threat and challenge, with adequate awareness and unlike the COVID-19, it's entirely we can prevent this, and with proper treatment and proper treatment of the usage of steroids and better early diagnosis and treatment. I hope this this was a useful presentation for all of you. Just exit my presentation and come back to the Zoom for the questions.
Thank you, Shankar, for this fantastic lecture. Shankar is a very close friend of mine and one of the finest ENT surgeons whom I ever know. He's been associated with Searchers for a very long time. He's a faculty in many of our MRCS classes as well. So if we have any doubts, I think we have a few doubts. Can you upload the PDF? Yes, we will try to do that. Some doubts on the diagnostic criteria. So there's this thing that, can you re-explain the diagnostic criteria?
See, it's very, very simple. First of all, when to suspect a case of mucormycosis. That's the main thing. So as of now, we'll just stick to the COVID-associated mucormycosis. So any patient who has been treated for COVID and the treatment consisted of immunomodulators and steroids, and also, for example, for like a long course of steroids. Patient with presence with complaints of any of the symptoms, right from the nasal symptoms, even be it a nasal block or nasal discharge or orbital pain or headache, whatever may be the symptom, we should not take it lightly. So diagnostic criteria, first criteria, symptoms wise, we have to look whether it is an criteria which is whether it can be symptom of mucormycosis. That's why we had these symptoms, for example, in the nose block, nasal discharge, crusting, discoloration. Because in the PDFs released by the organizations, they given that black discoloration, but many of them will not have this blackish discoloration or the necrotic tissue starting. So yeah, the early stage we have to take care of. Even you see, that's what I said. No, this patient, second patient, which I showed the diagnosis nasal endoscopy. He had symptom of only right eye discharge and right orbital pain. All the inflammatory markers were not elevated, and the CTPNS showed just maxillary sinusitis. But we should not leave it as such, and we should make sure that it is not fungal sinusitis. So for fungal sinusitis, MRI with the contrast is will be helpful. So that's how. The other case, maybe like just for the last 2-3 days, I've been seeing like quite a number of cases with this presentation. Today, one patient almost COVID post-treatment. She was not like, she's not an steroids also, not uncontrolled. Sugar status was under control only, but still presence of headache and earache. It just gave me a doubt that it could be a mucormycosis also. That's why. So, anyways, it's a thin line, but mostly all the major symptoms of the ENT symptoms like ear discharge and all should not be taken lightly. That's why. So criteria per se, presence of symptoms is one thing, but endoscopic view of the nasal mucosa is a must. If there is an obvious discoloration or necrotic tissue, just it's confirmed diagnosis, because once if there is a necrotic tissue, it will be more evident in the radiology. But if there is no evident obvious discoloration or blackish discoloration of the nasal mucosa, CT also is not conclusive, then take blind biopsies from the middle turbinate nasal septum or multiple areas, send it to the KOH mount or fungal identification. Till then watch out for the progress of other symptoms. So by the time the fungal results come, and by the time the patient is not developing any more symptoms and the radiology also is fine, then we can just be sure that it's not fungal.
Do we have any more doubts? I don't think so. So I think we'll end this presentation. Thank you so much, Shankar, for this very detailed and very comprehensive presentation on mucormycosis. Recently, today, I think Tamil Nadu government has also announced, and many other states have announced, that mucormycosis itself is an epidemic, and it is a real pressing issue which we are facing. So,
one more question: how can we make sure that how can we confirm free from the disease? So the thing is, as I said, that initial treatment comprises of surgical debridement and followed by antifungal treatment. So once the surgical debridement is done properly or well enough under all the possible conditions, where the amphotericin B will take effect. So there should be constant monitoring of the nasal mucosa as well as the radiological. Of course, the radiological improvement will take some time to revert back to the normal, but nasal endoscopy, direct visualization of the nasal mucosa will give us a clear picture about how the disease is progressing to the medications. So maybe like every weekly we should have a review of the examination findings. And once I said that minimum of 3 weeks of amphotericin B, even before 3 weeks, if the patient is showing a lot of improvement and clinically also there is no the mucosa is becoming normal, radiology is normal, then we can cut short the amphotericin B and switch over to the fosconazole. Anyways, we are going to give fosconazole or oral antifungal for almost like 3 to 6 months. So that's what.
thank you so much, Shankar. I think we have had a very exhaustive session, more than an hour, to be honest. And I must thank the entire audience. We had more than 100 people attending our lectures today. So we'll be posting the video on YouTube, and you can post the queries on our Searchtest YouTube channel in the comments. And I'm sure Shankar will be replying to all these queries within the next few days. Thank you so much.